I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. Today, I'm excited to have as our guest Dr. Nicole Ascanio, who's a family physician who went to, was it Wake Forest?
Yes, med school at Wake Forest.
Yep. And then did your residency training at
Cleveland Clinic.
At the Cleveland Clinic. And then she worked for a few hospital systems for a few years and then finally decided, you know what, this is not for me. We're going to do something different. Thank you for joining us.
Thank you for having me.
So, Nicole, why don't you tell us a little bit about yourself?
So I am one of four. I have three brothers, and kind of grew up always more interested in the science world. I kind of did think from a pretty young age that I wanted to be a doctor. I was into the medical field and helping people, and I had so many people that would be like, oh, you should be a nurse. And nurses are amazing. This is not to knock nurses at all, but I was like, I would like to be the doctor. And it was like from high school, when I first started undergrad, I knew how competitive it was to get into medical school. And I'm not just someone who just can take a test, and do amazing first time around on standardized testing. So I was like, I knew I needed to work hard. I knew what I needed to do. So it was just that. Get in, go to med school. And then when I got to residency, and when I got to med school, I kind of like floated around a couple different things. I wasn't sure exactly what I wanted to do. But I thought I wanted to do dermatology just because it like sounded nice, because I wanted a family. I wanted kids who I was home for breakfast and dinner. And I wanted to make money for the work that I had put in, right? For like the 20 years of education and all the debt. So I was like, this is a great field, but I just didn't like it. Like it just wasn't my thing. I loved general surgery. I did end up doing a year of general surgery residency and loved it, but it just I quickly realized that this is kind of more than what I wanted to have out of my career, because I always knew that I wanted kids and I would probably be in a position where I was always going to put them first. And as much as I tried to visualize it, I just couldn't see it. I think, when it comes to surgery, especially general surgery, you have to know that that's the only thing you can do to be happy. And I was like, I think I could do something else. So family medicine came because I couldn't see myself just seeing the same thing every single day, every single patient, same, kind of every day. I wanted to see, men and women, kids and adults, but not only kids, but not only adults, So family medicine was nice. Also procedural, and family medicine, we're able to do a lot. You can kind of tailor your practice at some point to certain things. And if you like procedures, you can do a lot of them. And if you hate them, you don't have to do any of them. So that's where I kind of went down family medicine pathway, went to residency for family practice. And in my residency, we actually did learn about different types of practices. We had a practice management block in third year. And whereas like the majority of people go and join a hospital-owned practice, we did discuss stuff like micro practices and just regular private practices, insurance-based private practices. We talked about direct primary care and concierge medicine and that kind of stuff. It was not, it was in a chunk of time, a block of time. It wasn't, it was kind of late in the game, I thought, because it was, I think, second half of third year. But still, I knew about it. And in my mind, I was always like, I'm doing something like this, because it wasn't lost on me from a very early point when we're rotating with these other hospital-owned family practice docs that the day-to-day is rough.
Sure.
Because you're just, for all kinds of reasons, right? So I was like, okay, I think like this is not what I'm going to do forever. And when I graduated, my husband had an extra year of fellowship, and then we moved to Omaha, and he was starting his practice. He's an ophthalmologist, and I joined a hospital system because it was just like we got bills to pay, mortgage, a kid and a half. So it, was the easy route to go at first. And then about 2.5 years in, it was just like, this is kind of all I've got to give to this. And I cannot do this anymore. And I was fortunate to be in a spot where I was not the primary income, to our household.
Sure.
So it did make it a little bit easier for me to make the transition because I wasn't the one responsible for, keeping food on the table solely. So I do absolutely understand it's hard to do a switch like that if you are the one who's bringing in everything for your household, but it's still possible. But more of what I wish I had done is done it from the start.
Sure. So what was it about what you were doing working for the hospital that made you decide, you know what, I'm done? And you mentioned in the back of your mind, you were already thinking about direct primary care. And so what were the frustrations or the obstacles in a conventional practice that pushed you over the edge?
There were 3 or 4 main ones. And the people were good. The people that I worked with, the other doctors in the practice and the medical assistants, they were good. But the system, which is the same system almost everywhere, at least as far as I'm concerned, it was RVU based. So this is how many patients you kind of have to see a day. This is your template. Here is your template that we will fill. These are your 20-minute blocks and your 15-minute blocks, something like that, or 30 and 15. And then you have to see this many, and then every month you get a report card. And that report card will tell you if you're productive enough or if you're below the average or above the average. And I was building for the first bit. So I wasn't full panel right off the bat. So I was kind of okay, I could do this. This is okay. But then once it was actually, once you're off your guarantee, this is how much your income's going to go down unless you fill. And then as time went on, I was more full. It was okay, also part of this report card is quality metrics. So you have to make sure A1Cs are well controlled, and you have to make sure that blood pressure is well controlled. All of the things that is the point, right? From my standpoint,
sure,
this is the point. So yes, I get that. But also patient satisfaction. So you've got these 3 things that you have to do well, or else your compensation goes down and you get in trouble or, whatever it may be. So that was so frustrating to me because I'm one of these things has to give, at least. You cannot have patient satisfaction without time. And if you have enough time, you don't have productivity. And honestly, quality comes from time, in my opinion, as well. Sure. So that was just kind of a constant frustration. And the other thing I realized was I had no control. So I would ask anyone over 60, honestly, you got to give me 30 minutes.
Right.
Because that doesn't boil down to 30 minutes. I would love 30 minutes face-to-face time. If I was actually in the office face-to-face with these people for 30 minutes, okay. But I'm pretty sure the studies show you've got 5 to 7 minutes face-to-face time with these patients. And so many of them are coming in, as we all know, at least in primary care, with head-to-toe concerns, multiple concerns at one time, because life is busy. So you don't have a lot of time to get into the doctor. And once you're there, you want to make sure you're hitting all your questions. You don't want to have to come back next week and deal with the whole process again, because it's a frustrating process to get in, to check in at the front desk, to wait, to answer the MA's questions, to wait for the you know what I mean?
Sure.
It's annoying. So they have all these questions, and I always would talk to my husband about it because he doesn't have to deal with any of that. Because as soon as they start talking about literally anything besides their vision, he's out. It's oh, you should talk to your doctor about that.
Sure.
I'm man, I really don't know that I want to be that doctor anymore, because it's the one that you just kind of gets dumped on. But I flipped that and I was that's not getting dumped on. This is what I want to do. I just can't do it this way. So you're putting out fires, you're throwing medications at stuff that probably could be fixed lifestyle wise. I hardly knew my patients. The nurse would come in at the end, later in the day, to ask me something about a patient from the morning, and I would just be who? I'd have to go back and look. I did not like know them. Every patient was seemingly new because there were so many, you know? So like you're starting fresh. So that was all so frustrating. And I realized how diluted people's primary care was. It is, and they don't even realize it because they think it's normal because the system has us seeing patients the same way they would have an ophthalmologist seeing patients who really truly needs just 5 or 10 minutes. You know, they talk to them for a couple of seconds, ask the questions, look at the eyes. This is what we're going to do. Great. You know, but for us, it's mental health, it's physical health, it's preventative care, it's chronic disease management, it's everything. So I was just like, this is, you either have to give in to the productivity model and let that drive you and only that drive you, or you have to do something different.
Sure.
And I just hated answering to people who didn't go to medical school and who were not taking on the liability. They were not taking, they were sitting in their desk job. Even just like the managers in the office, I was just like, I actually don't want to ask. Like, I want to tell you, this is how I'm going to do this. And I'm like, you can't in that kind of hospital owned environment.
Sure. So I was looking at a study recently that looked at the cost of healthcare these days. And I think it was, according to the numbers that they generated, it was about 18% of healthcare cost is the cost of the doctor. So if you go to see your doctor and let's say your visit is $100, which would be a bargain these days.
Yeah.
$18 of that goes to the doctor. Well, is the doctor only taking on 18% of the risk?
Right.
You know?
I mean, exactly.
You know, that's one of the huge frustrations. So what's different about what you do today?
So what I do now, I work for myself and there's nobody else involved. So with direct primary care, it's just me and the relationship with my patients who sign up. So it's a little different than true concierge medicine because concierge, that's how I kind of can explain it to patients and they get it unless they already understand what DPC is. But if they don't, I kind of explain that's the type of care you're getting. But a concierge doc usually is going to be a high retainer to some degree, and they bill your insurance just the same.
Sure.
So I'm like, this is just a monthly kind of like subscription model.
Like a gym membership.
Yes, exactly. And it works in so many different ways. Positively because one, it's not a fee for service. So patients aren't like, oh, I don't want to reach out. I don't want to go in because it's probably nothing. And I don't want to have to pay the couple $100 that's going to come in the mail later. You know, there's not that barrier of like, I'm going to have to pay something if I ask this question. It's like here, whether you use it or not, however much you use it. So it kind of encompasses everything and I have the time. I set my own schedule. I control how many patients I have on my panel, which directly impacts how much time I can give to everyone. So it's like more personalized. It's more comprehensive because I don't have to follow that. Like, here's the 3 labs every insurance covers for your annual physical, even though we're all different people. And, you know, why is insurance dictating how we're taking care of people? You know, I have lab, cash pricing for my labs, which allows me to get so many more, you know, not like all the fluff labs. I'm not getting 50 lab panels on people, but actionable, good labs that people should have a right to get. And they're cheap. They're dirt cheap. But if you go through insurance and you ask your doctor and, you know, it's like, well, that's going to be like, it could be anything, honestly, but it's probably about $160 for that vitamin D level. And it's just wild. So we can actually do what I feel like with my training is right for the patient without breaking the bank for them, actually saving them money in the long run, not crunched for time. We can actually treat the person as the person and not as one of 1,000 and do the same thing for everybody. And it's more convenient. So I can text my patients. I can answer so many medical questions in a quick email or text because I don't need to worry about getting paid for that and having it be tacked onto my RVUs. In a traditional setting, it's constantly make an appointment. You don't have time to answer everything, and you can't add that to your RVUs, so they have to come in all the time. So it's better for me. I'm more flexible. I can leave if I have to go volunteer at my daughter's Halloween party and not have to worry about my PTO hours. And I can, answer a patient's question at 6:00 at night because that doesn't bother me. It's just, it works so much better for me personally. And it is night and day, in my opinion, for patients.
That's awesome. So, obviously, that I have a direct care practice also.
Yeah.
When I talk to other doctors or when I talk to residents and medical students, those are the people that usually give me the biggest pushback. And they say, well, this is great. You must have all kinds of rich patients, and that's how you're able to support yourself. What do you say to them?
It's kind of funny. I just had this conversation the other day with somebody. I have a handful of patients that make a couple $1 million a year, and I've got patients who live paycheck to paycheck, and they don't have any insurance, and I'm the best, that better than nothing, right? And I've got everything in between. And if I had a full panel of only those who are quote rich with money to burn, I would burn out, because that's its own population, right, of patients. But I have everything in between, and a lot of it, the majority, I would say, are like 40s to 50s, and average income at best.
Sure.
So once people realize the value of it, and it's made to be, where I'm not looking to set a bar that is unattainable for the majority of people. I'm looking to set a bar that is attainable and I understand that for some people it doesn't work. It's not okay. It's not in the budget, and that's okay. But for the service that I feel like I'm giving and the time that I give, set a number that makes me feel good, that makes most patients feel good, and it works for everybody. And, you'll always have the people that are like, majority of people will tell me I'm not charging enough.
Sure.
Because if you I just had a physical therapy appointment myself, and it's like $165 for 1 hour.
Sure.
Yeah.
And
I paid it, not even thinking.
Right.
I'm just like, okay.
Exactly. And if it had been a subscription model, it would have been maybe $160 for the whole month.
Exactly.
And then you go in for as many times as you need to.
Yep. And no one's insurance is covering things anymore, because everyone has a high deductible plan, and no one wants to use it because everything is so expensive until you meet your deductible. So we're just wasting it all.
Exactly.
Burning money on. It's so frustrating.
Yeah. The average premium for a family of 4 these days is just over $25,000. And then the average deductible is close to $10,000. So you get to pay $35,000 out of pocket for the privilege of getting a bigger bill.
Yep, exactly. Because it takes something pretty big to spend $10,000 out of pocket. It takes a birth of a child, or a big injury, or a big health event that most of us are not having.
Sure.
But you could. So you kind of need a backup, but most of us are not having that. So no one is utilizing it. Mm-hmm. And it's so frustrating.
Yeah, for sure. So tell me, if you can remember, because it probably feels like a million years ago, when you were working for the hospital, if you had to guess, every time you saw a patient, how many different people were involved in that care, whether it was the receptionist, a biller, a coder, whoever, rough number?
Well, I can tell you. So you call and you talk to somebody to schedule, right? And then someone's putting that in the system. And then the person comes in and meets somebody at the front desk. So there's 2 or 3. And then the medical assistant who brings the patient back. And then myself. And then sometimes a diabetes educator. And sometimes a pharmacy person. And, just depending on what the visit is, because that's what they kept doing, is adding these things. And I'm like, I can educate on diabetes if I had the time. I don't need a pharmacist who is our diabetes educator to talk to the patient, but I don't have enough, you don't give me enough time. So, okay, let's let this person talk to him after, so I can see more to bill more. And then, yes, a biller. So, 10, probably 10.
Right. So you have 10 people whose incomes depend on your revenue generation. And so would it be fair to say that the overhead alone could be anywhere from 3 to 8 times as high as it would be in your model, where
absolutely
your only overhead is you?
Yep. No question.
So then the question becomes, so there, again, we have residents, we got medical students, people who are thinking about what they're going to do with their lives. Maybe even people who were in your shoes. They're working for a hospital right now, and and they're done.
They
they're
can't
done.
do
You
it.
know, like, you know, maybe Culver's is hiring. You know?
Seriously.
It'd be easier to
Wouldn't
flip
it be
burgers.
nice to be a barista?
Exactly. You know, and so how I mean, you talked about how this is affordable for the patients. That, you know, your average patient is an average patient, right? Well, how can you make it affordable for them? Spend all this time with them, and then still be able to make a living. I mean, you know, the average primary care doc these days, maybe they make $200,000 seeing 5,000 patients a year at 10 minutes a patient.
Yep.
You know, you're talking about spending anywhere from half an hour to an hour with each patient to make sure you actually get their care to them the way they deserve to have their care delivered. I mean, you're seeing 1/5, maybe 1/10 as many patients.
Probably less than that.
Yeah.
That's how it's done, is because, you know, you can, when they're in front of you, yes, they're getting a lot of time, but so many things are done like virtually.
Sure.
So much of what, like, they'll send me a couple messages. That sounds like a cold. Nothing sounds alarming right now. Look out for XYZ. Let me know if it doesn't clear up.
Sure.
So that person's not coming in, you know, or, you know, just let's follow up on your diet and send a couple messages back and forth. That person's not coming in front of me. And then the people who are in front of me, they get as much time as they need, really.
Sure.
And you set your number. So you've seen one direct primary care practice, you've seen one. So they're all a little bit different. So you kind of have to think, my patients talk a lot. I think they talk more to females than males. Sometimes I wonder, I'm like, would you send that message, you know, at this time or for this reason, or, you know, if it was my male counterpart. And I'm happy with the way that I know a lot about my patients, and they want to see pictures of my kids, you know, all that kind of stuff. So you set your number, you set what makes you feel good and feel valued. That also allows you to take care of the number of patients that you need, and you get to decide. So some see a lot more patients and they charge a bit less and things go a little bit quicker, and that's that. I think it is so doable, because that is all coming in month to month to your account, and your overhead, you have to keep your overhead low. That's key.
Sure.
That is very key. So, don't go get a big, elaborate, fancy office. Like, share space with somebody. I share space with my husband, but share space out of another private practice. You know, rent a space. You don't need a lot of space. Keeping overhead low, and then it's not going to a million different places. We have EMRs that are cheap. You don't need Epic. You don't need to spend, a ton of money on that stuff. Lab supplies all come free from the lab that you use. So at first it sounds like, how does that work? You're not charging enough, but you figure out what you want out of it.
Sure.
And how much you want to work. I could do a lot more, but I would come at the sacrifice of the family stuff. So I'm comfortable with right where I'm at, and someone else may, you can, that's the nice thing, is you make it what you want it to be.
Sure. So when you were working for the hospital, actually, let's go back even before that. When you were a resident, I mean, let's be frank, for all of us who were residents, our time had no value, right?
Yeah.
I mean, we were indentured servants. Some people would go so far as to say we were slave labor.
Yeah.
Right? The only difference is that we volunteered for it, right?
Yeah, honestly.
And then, you have this slave mentality, and some of us, maybe we even had some degree of Stockholm syndrome. We had come to love our captors, right?
Yep.
In some sense.
Yep.
And so you get accustomed to being told what you're worth. You get accustomed to somebody else determining your value.
Yep.
But that's not what you do now.
No.
So number one, how did you decide I wanted to determine my value?
Yeah.
And number two, how did you decide what that value was?
So I still think I'm figuring out what that value is. I think that is a moving target. And I think that inside the medical world, there's a ton of respect for primary care, because most specialists are just like, I could never. And thank you so much. And
that includes me.
Because they get it. They know what we are dealing with. They know every time that they say, that's not my thing. You need to, they know that it's going to that person who's getting that from all kinds of different directions. It's not fancy. It's not, it's not the most money that you're going to make. No one goes into primary care because they see the money signs. And that it's not respected as much in the outside world. Right. So in my mind, I feel like we should be at least in the middle, of the pack.
Sure.
And it's hard to say like, well, why does this person why is the average income from an orthopedic surgeon or a neurosurgeon so much higher? And yes, they're doing surgery, but it's all fee for service kind of stuff. And that's all about insurance and what insurance reimburses. Insurance doesn't reimburse primary care. So it's just not a fair system. So what they reimburse us for is number of visits, essentially. There's a few other procedures we can add in there, but that's how so it's like they're setting the value of you. The insurance reimbursements and Medicare, reimbursements are deciding who's the most valuable and who's the most prestigious and gets the most money and who doesn't. But if you think about what's the most important thing for the patient day to day in their life, I feel like we're equals. So what pushed me was honestly having to answer to a nurse manager about my template.
Sure.
And about days that I wanted off, and about leaving 30 minutes early to do a daycare thing, parent daycare thing, and having that constant like yucky feeling of like, oh, I don't want to have to go do this, or I don't want to have to ask for Christmas. Like I'm never going to work the day after Christmas. I am never going to do that.
Sure.
But someone has to in that world. And I was like, I got it off the last 2 years. It's probably my turn, but I don't want to do it. I worked so hard. You know what I mean? I'm the one with the medical degree. I want to be able to, to practice how I want to practice and how the patient should be taken care of. And I have zero say. And these people, like we talked about at the beginning, who have no liability, who aren't taking care of anybody, and who are just, going home at night and not losing sleep over any of this, are telling me how I'm going to make them money.
Sure.
And I was just done. And then I kind of thought, at that time when I started direct primary care, I think the average was like $80 a month. Mm-hmm. And that just didn't feel good to me because of what I know and what I can bring to a patient and the time that I know I will spend. And yes, I will answer that question at 7:00 at night if it's easy for me to quickly send a text, Sure. So like I kind of knew how I was with patients, and it just didn't feel good to me. So I started at $125 a month, and then I went up to $150, and that has felt a lot better.
Sure.
Because you can't feel, if you don't feel valued for what you're doing, every patient text is going to annoy you. Mm-hmm. You're not going to feel good about it. So you have to. It's so personal. It's such a personal thing. And there's people out there who are charging $250 for the same thing, and markets are different. So I think it's all fair game.
Sure.
I don't think anyone should have to be ashamed of charging something more for such a service. We're talking about someone's health.
Sure.
Day to day, primary care, their health. Like I said, I paid the PT $160 for, not quite an hour's worth of work.
Sure. Of which that PT probably didn't get half of that.
Absolutely. 100%. Yeah.
All the administrators got all the rest of that. So,
Yep.
So a lot of people in medicine these days, physicians, whether we're talking about people like you and me who've been doing this for a while, or whether we're talking about people who are, just about to step into the breach, mm-hmm. are really nervous about talking about money.
Yeah.
You know, like it's a dirty word.
Yeah, like we shouldn't make money.
Yeah, we shouldn't make money. We certainly shouldn't talk about making money.
Yeah,
that's
but
something that happens behind
everybody else
the scenes.
can. Everybody
Exactly.
else can.
So, what advice would you have for people who are starting to realize, you know what? Like you said, everybody else can talk about money. How come I can't? How do you help them break out of this?
It's tough because where we're making money is from people's health. And yes, everyone should have access to healthcare, no question. But that doesn't make us charity workers. Nobody else dedicates all of their 20s to working so hard. And maybe it comes easy for the occasional person, but for the majority of us, it is grueling for a decade. And it's expensive and it's delayed gratification. So you have to just continue to remember what you put into it and the liability that you're holding and what that's worth. And it's worth a lot. And you're also making up for all those years of lost wages, because you'll have friends who are graduating from college or grad school or even not making six figures immediately.
Sure.
And, you're delaying that by several years to then start paying back your loans that have an unbelievable amount of interest on them. It's like, let's be real here about this. And the work that you're doing is not easy. Like, you may be able to, I can easily titrate someone's blood pressure medication. I can do that. And I can do it quickly and without a lot of thought. But that's because of the last 20 years of work. So sometimes people are like, oh, well, just everyone else gets to do it. Sure. You're here to help people and to make a living.
Sure. And
the living that you want. Otherwise, go work overseas and build houses for people. You know what I mean? Like,
exactly. I mean, we don't have any problem talking with our carpenter about money. We don't have any problem talking to our attorney about money, or our accountant, or our electrician, or our plumber.
Like dentists.
Yeah.
Like, they're even in a different world. And therapists. Mm-hmm. It's just wild.
Yeah. You mentioned something earlier about healthcare. And, the conventional model, the insurance model, isn't really healthcare, is it? It's sick care. Yeah. Because, what are we incentivized to do? We're incentivized to drive patients into the office so that we can see them when they're sick. Mm-hmm. When they're healthy, there's no reason for them to come see us. Yeah. And so if they're healthy enough, they never come see us, which actually is bad for our bottom line. Right. Now, you don't want them so sick that they take up all of your time in the office.
Because that's very expensive.
Yeah.
Or in the hospital.
Yeah.
Then they become expensive.
You also don't want them so healthy. Speaking cynically here, right? Yeah. The way that the model is set up, the incentives are set up so that you want to keep them sick enough that they keep coming back to your office, but not so sick that they end up needing a 1-hour appointment.
Yep.
How is that different than what you do today?
Everything is about prevention. Keep people healthy. Keep them out of the office. You're actually taking care, you're doing what your med school and residency taught you to be able to do. You're actually able to do it. So you get back to the basics of lifestyle and barriers to change, and just the goal is not to increase bodies through the door. It's strictly just to practice medicine. And in primary care, that's yes, we treat chronic disease, we treat illnesses and stuff like that come up, but it's preventative and it's keeping people well. So it's a no-brainer in my mind.
Sure.
But it's so frustrating to see that we didn't ask for this. I think as a whole, doctors and, med students, residents, we didn't do anything to stop it.
Sure.
And now we are so far into it, this whole model and the, administration and insurance. And it's almost daunting to think of it ever dramatically changing.
Sure.
And it's such a game.
Yep.
And it's a complicated game that most people can't understand, so they just keep paying.
Right. And it's that way by design. Mm-hmm. So, okay. So as we wrap up, we've got medical students, we got residents, we got fellows, we got people right out of training who are listening, maybe even people who aren't right out of training, but people who are they're sick, they're tired of all the BS they've had to put up with.
Yeah.
What advice do you have for them? How do you get out? How do you break free? How do you shed the shackles of the conventional insurance model?
I would just say to understand that you are the doctor. You are the medical doctor who went to medical school, passed the tests, and understands your skill. Everybody else involved does not. If you continue to remind yourself of that, you kind of get that fire where you no longer want to put up with everything else. So you have to just keep reminding yourself and remembering your worth, and understand that it seems like, and we are taught, I think, in residency and medical school, that private practice is dead, right? And everything is getting scooped up, and private equity and, blah, blah, blah. And it sounds scary. And it's like, oh gosh, well, I just need to start paying my loans back, but remind yourself that there are other ways. And at first it's the harder path to follow, right? Because it's not easy to just do this. No one's doing it for you. But in the long run, it's what you deserve to do. It's almost like anything else besides doing it this way. Sure. You are just like a pawn in the game. Sure. And I'm sure I'm generalizing, but I can't see how it is that any other way when we have everything that we do dictated by what insurance will cover, what insurance will reimburse you, what Medicare decides to do, and what hospital admins tell you to do.
Sure.
I did not want to be told what to do anymore.
Sure.
Because I was the one taking care of the people, and I was the one getting in trouble and getting the bad reviews or getting the, report cards. Mm-hmm. So,
yeah,
knowing your worth.
For sure. So one last thing, and I don't want to miss this, because some of our listeners aren't physicians. Some of them are employers who are trying to figure out, how can I take better care of my employees? How can I save money for the company so that I can take better care of the people that make up the company? What do you say to the employers out there who are looking for a better way?
So I think it's been shown now year after year that direct primary care is a great option for employers to offer to employees, because when you offer them their insurance package, it's everything that we just talked about, right? You're not giving them better healthcare. You're giving them some access, absolutely. And it's really hard to get it outside of an employer. It's really expensive, but you're still just giving them that bottom of the barrel primary care. If you think about doing something a little bit outside the box and look at direct primary care, you're giving them such an unbelievable gift. And I can tell you, even from my patients who are paying themselves, I have a few employer groups, right? But they will never go back because they can't. They're like, I can't even step foot in a regular office now because of all the frustrations. But the employees and their families feel more valued. And those are the employees, if they feel valued by you because of what you give to them, they're happier and they're better employees, and they stay, and they're better taken care of, and their families are better taken care of. If we're just giving everybody this, again, bottom of the barrel healthcare, it's just frustrating. They're watching how much money it costs. This is a cheaper option for better care and happier, healthier employees.
Sure.
So it's like
everybody wins.
Everybody wins.
Yeah. Everybody wins so much that my practice, because I'm a small business owner, has contracted with you to provide direct primary care services for the people that I take care of. The people, I should say, that take care of me.
Yep.
The people that take care of my patients, the people that take care of my practice.
Yep.
So for those of you out there who are wondering, well, this is all great. Dr. Aguila talks about all these different things. I don't just talk the talk.
Yeah.
We got to walk the walk, and that's what we do. And I believe in direct primary care, which is the reason that my family's plugged in with direct primary care, and so is every other family that is involved in my practice.
Yep.
And thank you for that. Thank you for that opportunity. Thank you for, for helping us move the needle.
Yep.
Any other last thoughts?
I don't think so. Just continue to remember what you've done and your worth, and you can always say no. We're so scared of saying no, but we have to start.
Sure. Are you accepting new patients?
Always. Yes.
Okay. How can people find you?
So my website has everything you need to know. It's aspiremddirect.com. And you can also find me on Instagram. That has kind of dwindled as I've gotten busier. Mm-hmm. So if there's anyone out there interested in social media marketing, can reach out to me that way, because
Sure.
that's my least favorite thing to do these days. But aspiremddirect.com has all the information and a sign-up link or my email. So happy
And
to.
would that be a good way for medical students and residents to reach out to you with questions?
Yep. There's an email right there, and it goes right to me. Because again, it is only me. So sometimes people are like, I don't know who this is going to. Literally, it's just me. So I'll get it.
Awesome. Well, thank you for joining us today. We're excited to be collaborating with you. We're excited to have you on the podcast, and we're looking forward to all of you joining us on future episodes of this podcast as we talk to other pioneers and thought leaders in the direct care movement. Thank you. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.